So now we're going to talk about fractures and growth. And fractures are when bone tissue breaks. Because bone tissue is the most rigid tissue in the body, it is more likely to break than bend. However, bending can occur in childhood due to the way bones develop. And we'll talk more about that when we get into growth. Fractures are characterized on three characteristics. The first characteristic is shown here, the completion of the break. So you can have a complete break where the break goes all the way through the bone tissue, or you can have an incomplete break where the break doesn't go all the way through the tissue. And you can see that here in our diagram. The break stops here and this part of the bone is still intact. The next characteristic is the position of the bones after the break. You can have a displaced break or displaced fracture where the bones no longer line up, or you can have a non-displaced fracture where the bones still line up in their original alignment. Then we have penetration of the skin. So we can have a compound fracture. And the way I remember compound is it compounds your problems. So not only do you have a broken bone, but in a compound fracture, the bone has ruptured through the skin. It is actually poking outside of the body. And with a compound fracture, what I mean by compounding your problems, you have muscles and ligaments and tendons that have all been displaced, maybe damaged. You also have broken through the skin, so you have an increased risk of infection, because remember from our immune unit that the skin is the first line of defense against infection. And now we have ruptured that barrier. And so not only could you get infection in the wound, you could get infection in the bone itself because now it's exposed to the outside environment. Or you could have a closed fracture. This is also sometimes referred to as a simple fracture. So this is where the bones have stayed inside of the body and the skin is still intact. So as we talk about these bones fractures, we're going to talk about how these different categories that we just discussed kind of can come into play and kind of give us quite a bit of description around that fracture. With this first set of fractures, however, there's not a lot to talk about. Obviously, they're not displaced. They're obviously not open. So because the bone is still partially intact, chances are we're not seeing those second and third categories come into play here. So these are all our incomplete fractures. So the first one we have is bowing. So this is where the bone actually bends. And like I said earlier, this is what we see in childhood usually. We don't usually see this in adulthood because what happens here with bowing is the bone bends and we actually have some damage interiorly to the structure, but it's just slightly bent. A torus, or what we sometimes refer to as a buckle fracture, is where we have had significant damage to the bone. So much so that the bone has actually buckled and we actually have damage interiorly, although the fracture has not actually come to the surface. And what that means is that we actually see this characteristic bump occur when we have a torus fracture. Then we have a fissure. Sometimes this is referred to as a crack. And again, this is the defining feature here is that while the break is present, it's incomplete. And with a fissure fracture specifically, you cannot see daylight between the two pieces. That is juxtaposed against a green stick. Green stick gets its name. If you've ever gone outside in spring and tried to like break a stick, you might have ended up with like this strip of bark that may have been green tinged. And that is where green stick fractures get their name, is they come from this idea that there's still, a piece of the bone still intact. But if you look, you can actually see daylight here between the two pieces, whereas this one, it just isn't. It looks like it's just a crack. So these are our incomplete. And like I said, the other two categories are going to come more into play as we talk about these next set of fractures. So with our complete fractures, these are going to be all the ones that we can kind of see with complete. Linear or longitudinal, I'm sorry for the picture. I couldn't find a better one where it was more of a complete fracture where the crack goes all the way through. But with linear or longitudinal, what we mean by that is that the break or the fracture on the bone runs in line with the axis of the bone. So here it runs along the shaft of the bone. With transverse, the fracture runs at a 90 degree to the axis of the bone. So instead of running along the length, it runs at a perpendicular angle, and that's why it's called a transverse. And if we start thinking about this would probably be a closed because it is non-displaced. The bones are still in alignment with each other. So oftentimes, these get grouped together in that, like, usually if it's going to be open, it's also going to be displaced. But you don't necessarily have to be open if you're displaced. Next, we have oblique. Oblique is where the angle of the fracture is any degree other than 90 or vertical. So it's between vertical and 190 is the angle of the break. Then we have spiral. Spiral is just what it says. We have shearing of the bone, and the style of the break runs around the shaft of the bone. One of the characteristic aspects of this is that there are overlapping pieces. Like part of this bone sits on top of this. And with a spiral, how this happens is that the ends of the bone are turning in opposite directions. So this is common in like industrial accidents, where maybe someone has caught their appendage in like industrial equipment. And so the machinery is turning one direction while they're trying to get away in another direction. And so you see that spiral break. This is also characteristic of domestic violence, where the abuser is either has taken the appendage in two different hands and twisted in different ways, or you have the abuser grabbing the victim and the victim is trying to get away and they are twisting in opposite directions. And so you see that spiral break. So oftentimes spiral breaks, unless it's an industrial accident, will also be coupled with a domestic violence screener to make sure that the patient is not experiencing domestic violence. Next, we have comminuted breaks or comminuted fractures. And this is where the bone breaks into 3 or more pieces. So most commonly we see shattering of the bone. This is most common in like gunshot wounds, where the patient had a gunshot wound to an appendage. We see the shattering of the bone like this. Or sometimes like crushing accidents can have this happen as well. There are some subtypes of comminuted fractures we're going to discuss. First, First, we have segmental. This is where the bone is broken into 3 or more large pieces rather than shattered into tiny bits. So that's why it gets its own name. And then we also have butterfly fragments. This is where we have this like triangular shaped piece, kind of like a notch cut into the bone or broken into the bone. And this just mimics a butterfly's wing shape. So that's how it gets its name. So these 3 are all types of comminuted break. These are just 2 subtypes. Avulsion is where a piece breaks off the epiphysis of a bone. So remember, epiphysis are the ends and diaphysis is the shaft of the bone. And so in avulsion, we lose a piece off the end of the bone, off the epiphysis. Most commonly, what happens in order to create an avulsion is that the tendon or ligament has attached to the bone, has pulled and put so much tension on the bone that it tears a piece of the bone away. This can be common in individuals who have done a lot of weight training and put on a bunch of muscle mass in a very short period of time. Your muscle mass and your tendons are able to increase much faster than your bone tissue can be restructured. So when you're exercising and when you're weight training, like you are also restructuring your skeleton a little bit to add some more strength to those bones in order to support that increased muscle mass. But if you have weight training that has occurred very, very quickly over a short period of time, maybe due to things like steroid use or certain types of supplements, then you can have situations where your tendons and muscles have grown so strong that they actually start ripping apart your skeleton due to the amount of like stress they're putting on the bones. And then these are 3 special types of fractures. The first one is compression. Basically, once we grow into adulthood, we don't see the torus or buckling fractures anymore. We see compression fractures. And this is most common in the vertebrae. So that's the spine. And what happens is the weight crushes the vertebrae so that they actually collapse in on themselves. This is one of the reasons that someone might have their vertebrae fused, is if they have a vertebra that is got a compression fracture. One of the things we can do is fuse that to either the top or bottom vertebrae and keep it immobilized due to the nature of a compression fracture. The next one is a depressed fracture. This is actually a specific type of comminuted fracture, which makes sense when you look here. You can see all those different fragments, and comminuted is just a category of a bone that's broken into 3 or more pieces. So this is actually a specific type of comminuted fracture that we see in flat bones. So those would be the bones of the skull, those would be the ribs, the sternum. Those are all flat bones. And so what happens here is we actually see the bone kind of crack in on itself. And that's what a depressed fracture is. And then finally, we have the epiphyseal. Epiphyseal is where you have the diaphysis and the epiphysis have come detached from each other, either incompletely or completely. And that's this here. You can see that join between the diaphysis and the epiphysis, and it is completely removed from that. And the big concern about an epiphyseal fracture is the growth plate. So where the diaphysis and the epiphysis meet, we have what we call the growth plate, which is a thin layer of almost cartilaginous tissue where we have highly active osteocytes that are producing bone tissue to lengthen our bones. And over time, these growth plates actually solidify and become bone tissue themselves. But in children, they are still very much cartilaginous and they are producing that bone tissue. But what can happen with a fracture is that it can actually disrupt the functionality because the growth plates only know how to make bone tissue. They don't know how to make any more of this cartilaginous layer. They only know how to make bone tissue. So when they're healing, remember when we talked about like stroma or parenchyma? Well, this is that kind of situation where instead of being functionally growth plate, they're producing their final product, bone tissue, and they actually can calcify and solidify the growth plate prematurely. And so you can actually have stunted growth in that limb because the growth plate has been disrupted. So how does a fracture heal? So the first step is that a hematoma forms. This is basically like a scab. This is, a cushion of blood and healing factors that are right underneath that outer layer of the bone. And then once that happens, we are going to start reconstructing the blood vessels in order to supply this area with blood so that it can start healing. And we also start to have some spongy bone move into this area to start constructing the bone tissue. So we have some osteocytes moving in here. And then we continue to form that bony callus and fill in the space between the broken bones. And then we have the final stage, which is bone remodeling. So we'll actually reshape the bone in order to no longer have like this bulge on either side of the break and actually get the bone to be the proper shape. Sometimes this remodeling does not occur perfectly, and we end up with some scar tissue essentially on the bone. And depending on the age at which this happens, the older you are, the more likely you are to have that essentially bone scar tissue develop. So, how do we fix a break from a medical perspective? First, I want to talk a little bit about the external types of fixation. So fixation is what we call immobilizing the bones as they heal. So common types of external fixation are things you are absolutely familiar with. Something like a plaster cast or something like a boot or a sleeve. These are there to keep the bones from moving or shifting out of alignment so that that natural healing process we just talked about can take place. So the benefit of a plaster cast is that there is no shifting there. Unless something traumatic happens to this patient, there's not going to be any movement or shifting in those bones. They are totally immobilized. The downside of that is that if you have ever been to a doctor's office and had a cast removed or watched somebody get a cast removed, you will know that there is a very unique smell that comes out after that cast is removed, because so much dead skin accumulates on the inside of that cast. There's bacteria that love that dead skin, and none of that can be washed away because it would affect the plaster cast. So the downside of a plaster cast is that it really prevents regular hygiene from taking place, and that can cause other problems. The boot, on the other hand, these like removable fixation devices, these are nice because regular hygiene can take place. People can shower with them and such. It's a much easier way to manage a break from that standpoint. However, you do have to be more careful with them because shifting can occur. So this would only really be useful if it was an incomplete break where we're not expecting to see a lot of shifting. But it would kind of depend on the actual situation to determine which one of these would be necessary. So like I said, you are probably familiar with these, but there are other options for external fixation. So this is an immobilization external fixation device, and this is utilized when the bones need to heal, and then we need to reassess alignment at a later date. So here you can see there was quite a bit of shattering of the tibia. So we have a lot of comminuted pieces here. We also have some displacement in the fibula. And so what happens here is probably, this person is probably bedbound, and there isn't enough bone tissue here to get the bones to actually fit together again. So like if you've ever heard of setting a break, that's where, you know, you put the bones and lock them back into place so that they are aligned properly. But because there's a missing piece here of the tibia, there's nothing we can do. We can't set this break because there's no corresponding piece. So what we have to do is allow the bone to heal some. We need some reconstruction of this in order to be able to set this. So if you've ever heard of anybody having to have a break rebroken, chances are they had a situation similar to this. What we can do with this is that we can insert screws with these long rods on the end, and those can be attached to this adjustment piece. So here we have this external fixation device that works on, that can be adjusted to make sure that we have the right alignment of the leg. So we can actually turn these and pull the screws and adjust the bones so that as it's healing, we can kind of make sure that the bone is in fact staying straight. And so, like I said, this person would be bedbound. They would be in the hospital, and these adjustments would be made by their surgeon. We can also do internal fixation. So with internal fixation, we have lots of options. We can do screws, we can do plates, we can do rods, and we can even do pins. So 4 different ones there: screws, pins, plates, and rods. And this diagram shows all of those. So this shows screws being placed into a plate, but you could also just use a screw if you needed to, separate from a plate, if the bone was such that that would work. So a plate can be fixed to the bone, and then we can use screws to hold that in place and keep all of the pieces aligned. Then we can do the same thing with pins and rods. The thing about pins and rods are basically the same thing. It's just size difference. So you would use pins on smaller bones and rods on larger ones. So this is an intermedullary rod, and what that means is that we are going to drill out the medullary cavity of this bone, and then we're going to drive this rod into the medullary cavity, and that is going to provide support and allow for the bone to heal around it. This would be a permanent fixture. You could not remove this. And you would place an intermedullary rod if you were worried about support. If you didn't think that the bone, even after it healed, would be able to support the person, their weight specifically, you would implant a rod in order to act as that support. All right, so let's talk about growth. A growth plate is where new bone is built. And like I said, this is at the epiphysis and diaphysis seal. So this is where they meet. And growth plates are a remnant of development. And this is found just at the ends of long bones. So what happens with an infant? Well, let's start in embryo. So in an embryo, most of the bone is in fact cartilaginous. As we develop, we do get more bony tissue. As you can see, more of that cartilage is replaced. But still, major components of the skeleton are in fact cartilage. So major components are cartilage. And there's a benefit to that. That is what allows the baby to pass through the birth canal. The fact that a lot of their skeleton is in fact malleable allows for, the compression of the skeleton as it passes through the birth canal. In fact, infants are born without kneecaps. They do not have any patellas. They develop a patella later, and the fact that they do not have a patella means that they are able to crawl pain-free. And so as we age throughout childhood, we lose more and more of that cartilage, and it's only found in these growth plates, and they form new bone tissue, and that's how our bones grow in length. An infant can have up to 350 bones, whereas an adult has about 206. The reason for this discrepancy is because many of the bones fuse during development. So as we age, some of our bones that we're born with fuse together and become a solid piece. This is primarily seen in the skull, as we will see in the next lecture. We'll talk about that. And we see that fusion in the skull. So what are some factors that influence bone growth? So we have calcium. So we need calcium as a major component of bone tissue. Then we have phosphorus. This is what hardens bone tissue. Vitamin A is what helps regulate bone activity. Vitamin C is going to maintain the bone's matrix. In fact, vitamin C is really important for making sure that the bone matrix can support all the different functions it needs to. And then vitamin D is going to help build bone because it's what allows our body to absorb calcium. So vitamin D is actually something we make in the skin, and its importance is around making sure that we can absorb calcium. And that is going to round out our lecture about growth and fractures.